Hi, my name is Mark Lewandowski, and I'm one of the founders of Sono. We're an organization that provides education and value to hospices all over the country. And today we've got a very special presentation. It's actually going to be a discussion with Dr. Tim Ihrig. Dr. Tim, as we love to call him, is a nationally renowned palliative care expert. He's a physician, also a businessman, and working very hard to change the way that we think about healthcare and its delivery systems and its value. So Tim, thank you very much for being a part of what we're doing today.
Hey Mark, it's great to be here back at Sonos.
We wanted to talk to you today about the changes that are going on in healthcare, especially in our world of hospice, palliative care, value-based care. And I wanted to know if you would just start by telling us, what are you seeing as the future of the changes that hospices and people within our industry would want to know, and have maybe a better understanding of what the changes are going to be in the next year and what you might see in 5 years and then 10 years. What are some of those things that you see from your experience working with organizations in palliative care, in hospice, and with the federal government? What do you see as the future of our industry?
So great question, Mark. The landscape's changing tremendously, faster than it ever has before. So the context in which we present ourselves, the relevance of the work we do for end-of-life care has taken on a new sense of urgency and importance. And it's really reflective of what's going on in the macro world. So no longer is hospice this isolated entity that cares for people who are dying. It's taking on a potentially greater role. The importance of advanced illness care, hospice and upstream through quality palliative care, has never been more evident as the systems of medicine are transitioning from volume to value, value-based care, looking for better outcomes, and being held accountable, not just financially, but from a regulatory and compliance perspective in transitioning to better value, which is patient satisfaction, caregiver satisfaction, provider satisfaction, symptom management, quality scores, and certainly mitigating or decreasing per capita expenditure for the high-cost, high-need population. So it's a fast-changing world, and I think what is important is hospices need to realize they can't be isolated anymore. They have to understand all these moving parts so that they can translate the value of the care they bring to those other entities who are potential community partners.
Okay, so hospices see their unique and special place in this world, but their place seems to be small when we consider these behemoth healthcare organizations, these massive organizations of health systems, and you believe that hospice is going to take a greater role within that bigger equation. How might that be done?
To be determined, I guess. That's what we're talking about today. The catalyst for it being a much more important component of this bigger puzzle. You talk about these monolithic systems, recognize the economics. 15% of attributable lives of beneficiaries in this country utilize 80+% of the total healthcare spend. So that's just about $4 trillion annually, 20% of the gross domestic product of the US. It's hypothesized that's going to increase to 50, 60, even 70% of the GDP, same percentage of the population, over the next 2 decades. So while hospice may be small, as you referenced, it has a significant and can have a significant impact on the overall structure of the system because of the spend, because of the quality of care that's directly related to quality of life, length of life, and reduction in overall expenditures.
This enormous change in spending by this population, this is not a brand new concept. No. I was telling you earlier, in 1987, I met a guy named George Odiorn, who was Peter Drucker's assistant, and he made a presentation about the Odiorn model, and he was talking about this wave of the baby boom population moving through their life cycle and coming to a point in which they would be massive spenders of healthcare expenditures, and there would be such a small population of individuals behind them paying for that he believed that this was the big economic earthquake. And so what you're telling me is right now we got 15% of the people spending X amount of money, and then that's only going to get bigger. What is the solution? How do we bend that cost curve? How do we make sure that organizations survive when the current model is not working?
The electric light was not invented through the continuous improvement of candles. And so what we've seen over the last several decades is a restructuring of the Legos, the pieces that have made up the current healthcare model, in an attempt to mitigate the financial risk. It has failed time and again, and I offer it is likely to continue to fail unless we do things differently, which is put a focus on understanding advanced illness, looking beyond the linear algorithmic option of escalation of clinical intervention, which is really what the system's predicated on, which ties to the economic model, which is a fee-for-service model. I do something to you, whether it's warranted or not, whether the outcome is really positive or not, whether I've done it to you every day the last month or not, I'm guaranteed reimbursement. So the incentives are not aligned. The lever arm is really saying that doesn't work. We have to acknowledge it doesn't work. We need to throw away those Legos and create a new. So Don Berwick, former CMS chair, said, look, we got to kind of do away with the entire foundation of the system and come to it and say, what are the needs of this population? Defining those clearly and aligning relevant clinical interventions. We know that good care that aligns with where someone's at physiologically and the goals of care. Good care is less expensive. Good care is not synonymous with escalation of clinical interventions, but identifying how to care for these people. So it's not about healthcare reform. It's about reforming how we care. To your point earlier, hospice providers, astute palliative providers, understanding advanced illness, the trajectory, progression of disease, what is possible, what is not possible, have a much better understanding of what that care is about, can be about, and should be about than the rest of the industry.
Okay, I want to stop and ask a question. Is it presumption or arrogance that you would believe one guy in a conference in Arizona believes that the current system of provide care and build that care, provide care and bill for it, provide care and bill for it is broken, and that all of those people are wrong and a new model needs to be created? 1/5 of the U.S. economy is spent in healthcare. 1/5, $1 out of every 5 is just in healthcare. Certainly, that big behemoth machine can't be wrong.
It is. Absolutely 100%. For our population, all right? For 10 to 15% of the population, it is absolutely wrong. It has failed time and time again, and the statistics bear it out. Just look at the numbers. It's not me talking. Compare it to thinking differently and what the statistical and the economic numbers prove. So we have developed programs that think differently, and we have had people statistically live longer than the median expected age for any advanced disease, any age of diseased person. We've had a 70% per capita in reduction expenditures. So we've slashed the cost curve. We have people living longer, people living with a 98% satisfaction rate, with their caregivers having the highest rate of likelihood to refer others to this type of model. The system is wrong. I'm not calling out individuals, right? Because as a physician, right, I'm trained to recognize disease and debility and to do something to it. As that disease and debility increases, progresses, I'm trained to do more to it with the hopes of curing someone, keeping someone alive, subtextually defeating Mother Nature, which is an impossibility. Until we come to the recognition, 1, death is inevitable. 2, we have to think differently about those last months or even years of life from a physiologic perspective and align appropriate care choices, clinical interventions or other, with that time period. we're going to continue to repeat what has failed time and time again.
Take a moment, just a minute or two, to tell me about and tell the viewers, where did this passion come from? You were trained in a system and broke out of that system. Tell me just a little bit about that, just to give reference from where you're coming from.
That's a great question. You put me on the spot here, Mark.
Well, I mean, we've known each other a long time.
Yeah.
I can tell the story, but it would come better from you.
I think the reality is the very first patient I ever had. I mean, there's been a lot of influencing people in my life. My mother's a caregiver, some great mentors throughout my life. But the very first patient I ever had when I donned the long white coat, very first hour of being an actual physician, his name was Harold, and I've spoken about him before. He came to the VA where I was on call, and he had weeks of headaches that were getting progressively worse. And it turns out he was full of cancer, head to toe. And I was instructed by the attending physician to go tell Harold, the news and talk about his options. And I was stunned. I didn't know how to translate that. And so I did the only thing I knew how to do, is I came in and I sat down and held his hand and held his wife's hands. And they knew, Mark, this is the crucible of everything we're talking about. People know. Their little voice is the greatest prognostic indicator that's ever existed. It's better than a CAT scan, better than lab tests. He said, it's not good news. I said, no, it's full of cancer. And he said, what do we do? And I said, what do you want to do? He said, I want to go fishing. That I knew how to do. And it's that simple. It can be that simple. It can be translating some inevitable truths outside the guise of the clinical jargon and putting the fear of death in someone. So we can translate, how do you want to live whatever time you have given what you're dealing with? It changes the narrative and allows us to overcome fear, paralysis of the unknown. People don't say I'm scared of dying, they say I'm scared of getting dead between now and whenever. We know what's going to happen. We have to be stewards of translating that honestly, asking what's sacred to the individual, lining the two up, and there's your path. Right now, the question is, Mark, do you want to die? Never in 20 years had a patient say, yeah. It's never their goal. So we're trained, and we have a system that supports, if you don't want to die, here's the things we're going to do to you, rather than for you and with you. That's a clinical escalation. And at some point, it hurts you. You don't have the reserves to withstand continually, having things done to you. So we have to shift our mentality. We have to, I want to say, be more human than rote clinicians following a linear algorithm. It's not about restructuring the system to deliver primary care at home. There's value in that, right? But for our population, the needs are vastly different. We need different eyes to look at them. Taking the current care system and putting it in different locations just does that. It's the same care, different place. You're going to have the same outcomes. That's been borne out year after year. So we need to think differently.
Let's look at this from a macroeconomic standpoint. This problem that we're dealing with in healthcare, the rising cost of healthcare, the uncontrollable and unsustainable cost of healthcare, and the fact that we're not delivering healthcare appropriately to special populations, that's not just a U.S. problem. It's a global problem. It's all over. You and I know, we've got friends that call us from around the world, not just around the country, say, this is a big problem, can you help? Mm-hmm. But let's talk about domestically, just in the U.S. The federal government has an obligation to pay a certain amount of benefits to people in a certain older population. And then there are insurance carriers that come in and supplement those kinds of policies. And the bottom line is their goal is financial sustainability, not patient care. Mm-hmm. And so they've begun to examine or to consider examining reaching out to special entities, palliative care, hospice, to name a few, and say, can you be a part of the solution? And I think that's what really the viewers want to know is how can we build a system that is part of the solution? How can it benefit the patient and benefit the entity that's getting involved? Can you address that just a moment?
I'll try. We have to translate very clearly what we do, and we have to bring forth the data that shows what it is that meets their needs, which is financial, sustainability. We can cut the cost. We know that the care we deliver is quality care, and so people live better for whatever time period they're involved with our services. We manage symptoms better. We honor the entire human being and their caregivers, so that's an enhancement in their life. Those entities you mentioned, that's a means to their end. So to say that they don't care about that quality is a half-truth. If it accomplishes what they need, financial sustainability, and cost avoidance is profit for them, then they're all for it. The trouble is getting them to invest in these programs, right? Pay me now, create a program so we can deliver this care. It's guaranteed to pay off. We've proven that. But they want it done by restructuring again, all these different Legos or Lincoln Logs, the system that already exists. And that's difficult to do. Or they want these smaller entities, you and I, hospice and palliative, that sit outside these big systems to create these models that are across the entire continuum and have all the bells and whistles. We don't have the financial resources to do that. There's got to be some middle ground, right? We've got to be able to translate for them that we can do this, but it's got to be a joint effort. And so that's been an inexorable challenge over the last decade. The time where it was less formidable, the ACO Pioneer Project through CMMI, several years ago, allowed, I don't want to say unrestricted opportunity, but systems participating in that were certainly more influenced and willing to support financially programs to deliver the right care, right time across a continuum. But that's not continuing indefinitely. So I think we just need to get all the stakeholders together on both sides. So payers, systems, and hospice and palliative care to have this discussion. There's attempts to do this, like the Medicare Advantage carve-in, which we saw go live this year. One can speculate that no hospice entities were at the table when that came to fruition, that it was Medicare Advantage plans and others in an effort to change, the financial sustainability of caring for this population. It can't be a one-sided development. Unless we're all in this together and sitting down and saying, this is how it really works, this is what we can do, this is what we need from you, and vice versa, I think it is a dead end. No pun intended.
This is a really big challenge, and you and I and some partners, some friends of ours have been working on this challenge for years now. It's the difference between having a concept, and the concept is if you will give us a certain percentage, a certain type of your population, we can care for them better at a lower cost with better outcomes, and the outcome may not be a longer life. The outcome may be a better life for the last component of their life. So we've had these ideas, but when we first started getting there, it was too theoretical. It needed to be more something that had substantial numbers, some backing. Now, I have a PhD in business, so I'm a doctor of business. You're a doctor of medicine. We come at a problem from our training from two different perspectives. I was trained right out of business school that you protect shareholder wealth. That is your primary focus. Protect shareholder wealth. You came out of school saying you do everything you can do to help the patient. Somewhere in the middle of those two philosophies of what life is about has got to be a care model that is financially sustainable and good for the patient. Tell me about what it is that you're building that could be transitioned over to another entity and somebody could say, okay, this is the roadmap in which I could be successful helping in a Medicare carve-in?
Two components to that. One is all participants at the table need to realize what we talked about earlier, that the escalation of percentage of GDP going to this population is only going to exponentially increase. And so that threatens shareholder viability in the long run. So unless we change now, you've got no shareholders. Again, 60% of the GDP in the US is a global economic issue. And it changes everything about every aspect of our lives that we know today. So if you want to value your shareholders and you want to invest in them, this is a conversation that needs to happen now. They need to understand this so that we can accept change and meet in the middle. So what we're developing is, and what CAPCI is developing and what several organizations around the country is saying, okay, we need to acquire the data that proves better outcomes. Better outcomes meaning better quality, patient reported, better quality, caregiver reported, but also here's the financials. A 96% zero hospitalization rate for this population translates into hundreds of millions of dollars for one hospital, not system, one hospital. A reduction in length of stay in the hospital from 5 days to 2.7 days, right? Where you have an entity that can care for the individuals once they're discharged, so seamless across the care continuum, care, not disjointed, fragmented care, has value because it translates into those reduced hospitalizations, reduced escalation of care in this population that costs hospital systems money. So all these numbers are what are being borne out in systems and programs, much like we're creating at Crossroads. I developed prior to my tenure at Crossroads. We're translating them across a broader scope of service areas. We're taking what was accomplished in one affiliate in one rural hospital in Iowa nationally. And we need that aggregate data to take to the payers and to translate to them, this is what's needed, to take to the systems and say, we need your investment, we need your buy-in, to take to the shareholders and need that investment and buy-in as well to make more programs like this.
I'm very certain, and you brought up this earlier, I'm very certain that at the table, when a discussion was being had by these big organizations that are at risk on these dollars, and that they decided that they wanted to involve hospice or palliative care in the equation to decrease the cost, with a side note that it might improve patient care. We know that that's a big deal, patient care. So number one is, where are we going to get global aggregate data? I know right now you've got an average daily census in the palliative care group of 1,800, and that is maybe one of the largest in the United States. But as you're gathering that data, that sample size compared to the whole nation is going to be relatively small. Mm-hmm. So it's going to be good data, but it won't be enough data to convince the entire ACO, MCO, Medicare Advantage population that you're right about things. And next, where do you get the data that's so important to you and I and every hospice about patient satisfaction and family satisfaction, that my loved one was cared for correctly? Because if you pull them out of the big health system and you don't deliver a level of care that they're satisfied with, no one wins. Mm-hmm. The ACO or whoever's at risk says, we're going to pull the plug on this whole thing, mm-hmm. because the public relations disaster of a failure in palliative care is something they can't sustain. Many times they're more afraid of the loss of one front page article in the San Antonio newspaper than they are of $10 million of a mistake. That negative PR is worse for them than a $10 million loss. So where do you get the aggregate data? And how do you create statistically valid satisfaction metrics?
I would direct everybody to the Center to Advance Palliative Care. They are the national, if not global, leader in palliative care. And everything we're talking about, as far as a centralized repository for entities to input their data and they put it all together and it's accessible, as well as helping organizations understand what those data points need to be. I'm not a statistician. I practice medicine, but you have to make that understanding of what's needed, again, so you can translate it across this continuum to all the relevant community partners. CAPC is the space. They are doing phenomenal work. They have for a long time. Dr. Diane Meyer, who founded it, just stepped down as a CEO.
Diane Meyer was a mentor of yours and a very close friend.
Yeah, I'd say absolutely a mentor and friend, absolutely. And that, again, we don't need to reinvent the wheel. Use the resources that are there. The thing that needs to happen, Mark, is translating care opportunities. That's a little different, okay?
Yes.
And that's the clinical eyes and ears with which we engage with the human being and understand where they're at and make relevant care choices pursuant to what their goals of care are and what's sacred to them. That's individual by individual, organization by organization. We need a new mental model about how we think about life, how we think about death, how we think about the approach to that, and what may influence to the positive or to the negative that journey. And that's in development. I mean, that's a long ways off, because that's challenging the entire paradigm of how we're trained. It's challenging the entire paradigm of how the system is set up and predicated on what we do and why.
If I'm a 50-year-old cardiovascular patient, I want my cardiologist to know the analytical models of great care and the very best outcomes based on changing data points all along the continuation of my care. But we're talking about an intuitive approach to knowing which patients to pull out of the system that need to belong in this new environment. How do you make a modification and change from a systematic approach to care to an intuitive approach to care?
It's not entirely intuitive. There's a lot of good models out there. They can use claims data. They can use all kinds of metrics and biologic markers to identify 2 or 3 years ahead of time, from a systems perspective, who's going to cost them money, who's going to be the high cost patient, right? And so a lot of systems are already doing that. They're identifying a subset of their beneficiaries that are going to be the high cost, high need patients, right? So that's the first thing that needs to be done. Okay. What is missing, they're tagging them all, right? But it doesn't change the care delivery. They're still delivering the same care, which is escalation of clinical intervention. So even if I tag you and I say, I know that you're going to cost me a lot of money, they're paralyzed with respect, what do you do with that? So they can get you to physical therapy, they can get you to home care services, they can get you all these ancillary services which have value, right? But it fundamentally doesn't change the path that you're on is an escalation of clinical intervention until you're dead. So the outcomes, they'll say the variance in per capita expenditures, change, but I think the aggregate accountable care organization per capita expenditure decrease a couple of years ago, right, was 1.25%. So think of the hundreds of millions, if not billions of dollars that are spent to change how we care for advanced illness population and all the person hours put into it, restructuring palliative care at home or primary care at home and this and that, to bend the cost curve by less than a couple percent. I would offer we probably spent more to get that than we saved. So you can identify people. We're good at that. What we do with that, that's the key.
The big organization that has an at-risk population and they have advanced illness can target or select individuals, but at some point, we've got to pass those individuals into a new group who are going to care for them in a different way, a completely new paradigm, a complete change of the protocols.
And it can be a melding. They can be concurrent for a time period.
Okay, how do we get those people trained in the very best ways to do that?
Right.
Because you don't just take advanced illness and put them in hospice, because that's not exactly what they need. You don't. So imagine that if there are 4,000 hospices in the United States, the vast majority of them have a name that includes some kind of language, some kind of nomenclature that refers to palliative care. Yet very few of them, if any, are delivering a real, true palliative care model and doing it in a way that's financially sustainable and something that they can actually put their finger on and that there's metrics involved. So you and I both know that at some point there's got to be a transfer of knowledge from those of us, specifically you, who have done this, who have proven it, who have a census, who have got results, have got data, and now there's a model of transfer. Can you talk about that a little bit? What do you see that looking like in the future?
I'm not going to be a pessimist, but I unfortunately think there's going to have to be that approaching economic catastrophic, implications of everything we've talked about before people gravitate towards really integrating this type of care into their systems. Because the financial lever arms are not big enough right now. The financial penalties are not big enough right now. CMS and your commercial payers, there's not enough teeth in, holding people accountable for what's being done incorrectly. And until there is, they're not going to change. Fee-for-service industry is just that. The more I do to you, the more money, I stand to make. If there's one of me, and I'm guaranteed reimbursement, why not make 20 of me? 20 times the revenue stream. Until they're held accountable financially. Real money.
Yeah, business school lesson number one is politics is too important to be left to politicians. The amount of revenue that's created in the system of healthcare delivering in its current model is so strong, it's so powerful, it's so influential that there is no legislative body that can ever make a real modification to it without cutting off their nose to spite their face. They would immediately be abandoned by all the big money givers. And therefore they would no longer be able to be a politician, have that kind of power and influence. So we've got a real problem. We've got a very significant problem in that we know there's a challenge. We know there's a cliff coming. The cliff is right there. It's just a few years away. And we're seeing an inkling of discussions in the Medicare Advantage environment saying, hey, we need to do something about this. Maybe we take this sickest of a population and we put it somewhere else where it can be managed more cost effectively with the same or better outcome. Now, I don't really believe they believe it's a better outcome, but I do.
Sure.
I believe it's a better outcome.
Well, I know
but
it is.
It's certainly a cost reduction. Those people that back large healthcare organizations are looking for a way to mitigate their downstream risk. And that downstream risk is those populations staying in the same system without changing models. So we've got a big challenge ahead.
Absolutely. It's doable.
Okay, dream for me. Dream. Go crazy. Say things you're not held accountable to. This is my fault. Dream big. What do you see the future? How do we bend this cost curve? How do we make these changes?
It's got to be a revolution of thought, Mark. And I think it sits outside of a system. It sits outside of a provider. I think it's a social construct. We have to think differently. And these are some lessons from Tanzania, my time in Tanzania, where I've done a fair amount of work. We're talking about industrialized healthcare countries. Right? People in Tanzania, it's not an industrialized healthcare system. They don't want to die any more than you and I. They recognize the inevitability of life. And I will say that they acknowledge it, which allows them to accept it, which allows them to create a vernacular to talk differently about it, which translates into care choices which are somewhat independent of their resources or lack thereof, right? That are consistent with where somebody's at on their trajectory of life. And so that shifts their paradigm from fear-based that we talked about earlier, which is paralyzing, I'm afraid of dying, to I want to engage in how I can live, right? And that's the shift that needs to happen from a cultural perspective. When we do that, I think we can start to get some traction. When I sit down one-on-one with the heads of states of large monolithic organizations, business, healthcare, and we talk about their experience with their mother or their grandmother or their grandfather, this all translates. It's very clear, right? So it's a human conversation, much more than a business or a medicalized conversation. When we get back to that component, and that's the foundation from where we start to move forward and say, what are the options? How do we translate what we have into a different paradigm for this population, right? For 10 to 15% of the population. That's what I think needs to happen. It's got to be an awakening. Without that, we're stagnant. Without that, Mark, what I've seen in my career is, unfortunately, people die many times before they're dead. We are stealing from people the opportunity to choose how they want to live. Okay? We're stealing hope. We're stealing choice. Albeit we are not recognizing we're stealing choice because we're so ingrained in this escalation of clinical intervention and fighting a disease and overcoming Mother Nature, which is absolutely 100% impossible. And I'm not saying don't fight. We have to fight appropriately. We have to find those mechanisms of caring for someone and with someone that are appropriate given where they're at on their physiologic journey. That's a human issue. We need to get back to that.
You talked for just about, used the word vernacular, which is the use of language within a specific culture, which is a very good term. It's great because in Tanzania, the vernacular is different than the United States. We had a conversation yesterday on the golf course with two people that we just got to talking about hospice and how beautiful hospice is and how important it is to have the ability to talk about it in a meaningful way and discuss living beautifully till the end of your life instead of the fear of death. It's a whole change of mentality. And it's very exciting to consider how would we go about making that change. But right now, I don't see a easy method for us to change that working vernacular in the United States unless we rally every resource we've got to us and say, let's combine and be one voice and let's get that voice out there. The challenge is that in medicine, there's a phrase, do no harm, right? So in their mind, do no harm is give them as many treatments as possible without a change that says doing no harm at some point means stop treating them and let them go. Let them live. That's a big challenge.
So I'm going to challenge that a little bit.
Okay, please do.
I think we always treat, right? Treatment takes on a different meaning given the eyes of the beholder, right? The oncologist treatment's a lot different than me as a palliative care physician. Treating is not synonymous with caring. Okay? And a CMO of a large system once said, look, I like hospice and palliative because it's treat, and then we can care. And I said, well, why don't we care the entire time, right?
Yeah.
And, unfortunately, as a physician, I referenced how I'm trained to do something to disease and debility, but I'm also trained, unfortunately, to have this false belief that death doesn't exist or death is optional or that death is synonymous with failing, right? Mm-hmm. Why would I choose a career where 100% of the time I'm going to fail? Because every patient that I ever see, whether I'm a pediatrician or a hospice physician, right? Every patient that I ever see is going to die. Hopefully not by my hands, but everybody's going to die. Until we acknowledge that, and this ties into Tanzania, the acknowledgement that this is life, we are going to be stuck in this rut because the physicians feel that if they don't provide treatment options, which is synonymous for them with caring, if someone dies, I have failed. Right? It's a self-fulfilling prophecy, and it's cyclic. Hospice in and of itself is not about dying. Right? So you use the word, you don't use the word. As a hospice physician, I don't, it's not going to bother me if you never say the H word ever. It's about living. And that's what we need to have translated to our other providers, to my oncologist friends and my cardiologist friends, who I have the utmost respect for, right? I couldn't be an oncologist. But we have to understand our limitations, and we have to reframe what's possible. And we have to provide for ourselves the opportunity to acknowledge, accept, translate, and communicate the realities of what's going to happen so that we can empower living rather than just fear of death. And, you got to keep taking treatments or you're not a fighter, you're giving up. No. We have to define what we're fighting for.
So what role should a viewer who owns or runs a hospice take as they're looking at this Medicare Advantage carve-in? What's their role? What should they do? What are steps that they should do to be part of this solution instead of watching it from the sidelines?
Great question. You have to recognize that this is the way of the future. So for 30 years, hospice has, I don't want to say been stagnant, but we've been self-isolated. We do the right thing, we do the good thing. It is some component of touchy-feely. It's quality outcomes for patient satisfaction, caregiver satisfaction. But that's not enough anymore. Unless we are able to translate, that care and the economics of it to potential community partners, your viability is short run. Because the hospices that understand everything that's going on in the macro world and understand that they need the data, they need to translate that, are going to have a bigger runway and more opportunities. The MA carve-in is reflective of the larger system of medicine trying to mitigate their downside financial risk for high-cost, high-need people. The short run, right, 40% of all eligible CMS, all eligible Medicare population falls inside of an MA or MA plans right now. That's 50% of the population that we deal with. That's a huge number. You better be versed in who those entities are and how they play ball, because they're the referral sources. You better make yourself aligned with how we can provide care for them, or you've just cut one foot off. 50% of your referral stream is gone, potentially. I only see the MA space increasing over the next decade. But here's the paradox, right, that you talked to earlier. With the economic catastrophe that looms, is the MA space, is any current payer-provider space feasible a decade or two from now? I don't think so, without change, right? So hospices need to increase their knowledge of what's going on in the space to maintain and elevate their relevance with those community partners now. And the hope is that union will translate into greater change across the entire market space so that we're all here in 20 years. Does that make sense?
It does. It does. It worries me. I think, the space could exist with greater and significant taxation. Inflation of the dollar could help at some point, but it would decrease the value to the older population trying to pay for Medicare because their dollars would go for less. We've got a really big challenge there. The biggest challenge I see too is that, or one of the challenges I see is that a hospice wanting to get involved in a Medicare carve-in will model palliative care in the same or similar manner in which they modeled hospice care. And that's not always sustainable.
Absolutely not. Have to recognize the differences. Hospice goggles will get you into trouble, if you try to move that upstream, because there's exponentially more challenges and variances outside of hospice than within this sandbox of hospice. So one should talk to other organizations that have been there, done that, right? So when I talk with people around the country, the greatest thing I can offer is there's 1,000 mistakes that can be made, and I've made them all, right? So let's learn from those in aggregate. And let's bring forth a model upstream of hospice that has real value to patients and families, providers, is economically viable, right? Another false belief is that palliative care is a lost loser financially. It doesn't have to be.
So you do believe that Medicare carve-in is a upstream opportunity for hospice for a downstream result into their hospice at some point?
At some level, yes. There's still a lot of unknowns. Right? How is this going to play out? It started January 1st of this year. I've seen no preliminary data. On top of a pandemic, there's consternating factors that really preclude us from understanding what's going on at this given moment in time. I would say we need to have this conversation again in 12 months and hopefully have some data to reflect on what the MA Carvin hospice has looked like, what some of those outcomes are financially, satisfaction-wise, timeliness. They're looking at several criteria, timeliness, length of stay, less than 6 days, greater than 180 days, symptom management, how many days did the individual have in their home the last 6 months of life, some rudimentary metrics, but it'll give us a big, broad brush overview of what's going on and where we need to go from there.
How does a hospice get involved with a organization that could provide them patients in a Carvin environment?
So it's closed right now. So that window was open a year and a half ago, and to the best of my knowledge, CMS had says for the pilot, the demonstration project, which is 4 years, they're not going to open it again. However, one could speculate that maybe 2 years in, so 2 years from now, there may be opportunities for MA plans to vie in, as well as hospice organizations. But right now, we're kind of on hold. So we'll just wait and see how the providers who are engaged right now, what their experience is like.
And at this point, we're just hoping to find data. We're not guaranteed of where that data is going to come and at what time period that's going to come. That will provide us objective metrics on how successful this type of program is.
Yeah, it'll come. What's the time frame? I don't know. I don't think it precludes hospice organizations from really heightening their awareness of what's going on in alternative payment models. The MA Carvin is just one, right? There's lots out there. You have to verse yourself in what is happening again in the macro world, so you can find what is most relevant to your organization. An organization like ours, with an ADC of several thousand is potentially different than an organization that has an ADC of 25. And not everything may be similar to both organizations. And the runway of what we have to deal with and how quickly we need to act certainly is different. But even for our organization, which I would offer economically has a longer runway than smaller groups, we're acting now. We can't wait. If you wait 5 years from now, I'm afraid you're potentially not going to be around.
What are the things in regard to the Medicare Carve-In that keep you up at night? Something that I haven't had enough understanding to bring into this discussion today. What is it that you think about that worries you?
Wow, now you're going to make me a potential conspiracy theorist. Obviously, patient care is front and center. What is the care going to look like? How is that relationship potentially going to change care delivery? So for the first 2 years, we know that CMS had said, MA plans, you have to pay current rates for hospice care, right? If you're going to have this union and the demonstration product, that's non-negotiable. So hospice organizations can provide the same level of care and be guaranteed reimbursement that they would with any other community relationship. That's a great thing. What happens after that, I don't know, right? So patient care is first and foremost on my mind. An underlying current that I struggle with, as well as a lot of colleagues around the country, is what was the onus of the MA hospice Carvin? Again, none of us were at the table to say this may be a good idea to increase hospice opportunities to a larger beneficiary pool. Those that previously, who were in an MA plan, were essentially precluded from it unless they opted out of the MA plan and went to a hospice. We weren't at the table. So the architects of it is still relatively unknown, at least to me. One may speculate, given who controls most of the lever arms in healthcare these days, that there is a goal to own birth to death, to mitigate any financial risk and to make as much money as possible. That's business. You're the business doctor. So that makes sense from a business perspective, but that has potential downside negative effects on care delivery. If it's solely about mitigating finances, it may end up cutting services and negating care opportunities that you and I recognize, being in the hospice space, exist every day, every hour, every minute. So there's a lot on my mind, and I have to take a deep breath because, hopefully within the next 12 to 18 months, we'll have some answers or suggestions of what the answers may be, so we can know what our voice needs to be in the aggregate. So we in the hospice industry, we need to come together. We need to be a unified voice that understands everything we're talking about today, so that we can be an influencing factor and sit at that table.
Yes, that is absolutely right. My hope is with our organization, Sono, we'll become a more influential organization as we grow and provide a greater voice to the legislation environment, maybe community leaders, national leaders, thought leaders, those that have a voice. But right now, it's such a divided, broken up, disparate industry. There's not enough people coming together, rallying with a single voice to get a message out. The other thing I'm hopeful that as we move down this road in which hospice is going to be a part of the care model for large organizations, that we will then have a methodology to train smaller hospice organizations to be successful. Whether it's in a rural community or even a metropolitan, if they've got the quality staff and they've got the model, the methodology to deliver that kind of care, why shouldn't they be a part of it?
Absolutely. And I would offer, in addition to that, we need an educational care model that starts day one of medical and allied health matriculation. Because the mentality that is demonstrated, that we've talked about today, escalation of clinical care, that starts day one in med school. We need to change how we're trained. So we need providers in the service area now that are delivering care pursuant to what we're talking about. But we need the next generations of physicians and nurses and phlebotomists and administrators to be able to think differently. And while we're all still catching our breath from the last 13 months because of the COVID pandemic, and so many people have struggled just to stay alive financially, what an opportunity to say we need to come together, and I need you, hospice organization B, C, D, and E, and you need me, because we need to change the paradigm of what's going on as one entity. So let's start now, right? We've recovered and are recovering from a pandemic. Let's look to the future.
Tim, thank you very much for taking time today to share your ideas, your thoughts, your dreams, take a risk with me.
Thank you.
I wanted to push you to say things that you might be embarrassed or sorry that you said, but it was
Well, if I see a pink
good.
slip in my mailbox next week, I know who to thank.
Well,
So.
that would be my fault. Don't come looking for a job. No. I can't afford you. I just wanted to say thank you for all the viewers for taking time to watch this. This is going to be an ongoing part of who we are at Sono, is to look at the future and try to find experts to help us navigate that. The future is very real and very challenging, but it can be an opportunity for every one of us if we stick together, if we learn, if we change, if we're prepared for it. So if you liked what you saw today, don't miss Dr. Tim Ihrig on his your TED Talk. You have a TED Talk. It's a few years old, but it's absolutely fantastic. If you've never seen it, it'll give you his real true understanding and belief about palliative care. And I think it's breathtaking, a breath of fresh air. That's what I was trying to say. Sometimes my brain gets in the way of my mouth. Anyway, thank you very much. We look forward to the very next episode. We talk to Tim again for sure in 12 months to find out how are we doing with all the things that we projected and all the beliefs that we thought would change the world. Thank you very much, Tim.
Thank you, Mark.
Okay, now we sit and talk and chat and do that.
How was that?
That was fantastic.
Okay, before you ungarb or anything like that, I'm going to ask a question in case you want to film it and edit it. I don't know if it's
Okay.
It's relative, I just don't know if you want it in your talk or not.
Okay, I'm recording.
So, for a second, let's separate hospice and palliative, because those are two different things because of regulations and payment methodologies and knowledge. In hospice, we've been operating under one set of regs that has been modified over the years for 40 years. We've been getting paid for 40 years. So we've got a 40-year head start on palliative. So my question is, and forgive my wording, I was trying to talk while you're going through it, is regarding getting a seat at the table with regard to managed care. So don't we need, because you really need hospice and palliative care, but those are two different things in payment methodologies. So don't we need a consolidation of CAPC to develop levels of care, 2 years and less, 2 to 4 years, chronic care management, for all palliative providers to sign on to follow, which would be the formation of their initial baby regs to start, with how to, how often, mitigation guidance, etc., before we as providers can ever demand a seat at the table, because our outcomes are more consistent across the spectrum if we're following the same set of regs.
That's a great question. Yeah.
So how can we expect the managed care organization and others to acknowledge palliative care place when we cannot amongst ourselves agree as to what we do and how to do it?
So, understanding that palliative care is in its infancy, pre-adolescence. We're a decade plus since accreditation. There is no general consensus, and we're working on it, right, with what it is, can, and should be. Over the last decade, we've seen how many organizations hang a shingle outside that say palliative care, and it has a different meaning. It has a different meaning inside a health system, where it's under oncology versus an independent provider out in the field. And then all the different perspectives we take on what it means to be a caregiver in the modern age, right? Linear algorithmic escalation of care versus more of a humanistic, and this amalgam of everything in between. So to say that a consistent palliative paradigm is lacking is an understatement, right? It has taken on as many variations as there are shades of blue. And we do need that. Can we wait for that consensus? I say no. Because do I see it happening in the next year? No. Has CAPC and Diane and palliative providers across the country been working diligently on this for the past decade? Yeah. But it is a huge task. Look at consistency, evidence-based medicine for internal medicine. How many decades, centuries old is that? And there's still some disparities. So I think we need to do this concurrently. We need to say this is the best practice, and if this is a model that proved quality outcomes and mitigated downside financial risk, we need to pilot that. We need to take those opportunities and have larger systems implant them and say, maybe we do it across a certain population. Maybe it's congestive heart failure, and here's the criteria. But we need to do that 1,000 times simultaneously and pick what works. Because waiting for us to have a consensus, waiting for human beings to have a consensus, this financial catastrophe is going to happen long before that happens, I would imagine. So it's a great point in that one of the greatest obstacles is self-imposed. Our tribe of palliative care practitioners are lacking consistency. We've got a lot more than we did a decade ago. Accreditation is happening as far as testing, fellowships, nurse practitioners, et cetera, et cetera. But that bar needs to be much, much higher. And it needs to be across the entire continuum.
Mr. Farmer makes a great point. We are living in a hospice environment that's very much like a craftsman industry environment. Every hospice believes that the way they do it is the very best way. It's part of their personality. It's part of who they are. They love what they do. And that's why they don't hand off things well to other people. There have been organizations that believe they could come in and do all the back end for 25 different hospices and do it really well. And they've run into terrible results because no one wants to give up the administration of their hospice because they believe they do it well. And to go from a craftsman industry to more like a specialization and exchange, more of a systematic approach to care is going to be very difficult in the hospice sector. But within palliative care, if we really want to make it transition from a part of Medicare Advantage into a palliative care organization, it's going to have to be systematic. I will say this, the other reason it's going to have to be systematic, if it's an ACO, an MCO, a hospital system, whoever's holding the risk of that patient population doesn't hold the risk by themselves. They've got stop loss or reinsurance, a contract with Lloyd's of London, somebody that's helping them hold the risk on this massive amount of money. And so if you're going to prove to them and convince them to give you a chance to help manage their money, you're going to have to prove to the sharpest financial minds that you've got data, you have systems, and you know exactly what you're talking about. And if you have 100 different approaches to the same care, you're going to run into a challenge. You're not going to be able to convince the at-risk party that they can deploy a program through multiple vendors and get a similar result outcome that they need financially.
Unless, as a hospice palliative provider, you're willing to take on that risk as well. The joint risk, right? If I'm going to go at risk, that is a lot more attractive. And we're not there yet. I mean,
a shared risk model.
Gets everybody much more at the table than me trying to convince you I can do it. I'm on the hook for doing it.
What's the size of a hospice that can then be part of a shared risk model where another one cannot? A 55 ADC
It depends on the community.
I think it would be very
I think
challenging.
it depends on the community.
It also depends on the entrepreneur or the organization
Yeah.
that owns it. And are they willing to take the risk?
Yeah. I do think, this is a segue into maybe our next segment. But
I love it. Yes.
shared risk, I think, is the future, because then, you are accountable for your outcomes. They don't have to believe it. You just have to prove it.
However, and I want this to be a topic of next time when we talk about this shared risk model, does it change the way the organization provides care and caring when they're worried about the money?
It doesn't have to. If we go back to what I talked about earlier, if you think differently about the paradigm of care, right? If you lead with that, which is all I've ever done, and programs we've developed, that's all that's ever been at the foundation, right? The financial outcomes, they just happen. When you give the right care, the right time, right reason, good care for those on those points is less expensive care. You don't have to change how you care.
I want to make sure that we reiterate one item. We believe that planning on Medicare Carve-In took place probably without palliative care or hospice knowledge whatsoever. These are large entities that said, we need to push this downstream, let's push it here. So because we were not at the table, we really don't know what was discussed. And if we don't know what it is that they really wanted, how can we give it to them? Therefore, we've got to be more involved at the decision table. And that's my hope out of this, one of my hopes out of this conversation. Again, thank you very much.
Thank you, Mark.
Maybe we should have started with the whole argument, yelling and screaming at the very beginning. This has been a great bonus session. Thanks everyone for listening. We'll talk to you next time.